So it's Friday, so it's time for Poets. Some of us know that as Push Off Early, tomorrow's Saturday. But in this context, it's the Perioperative Enhancement Team. Inspired by Dr. Sol Aronson and the team at Duke, a selection of clips to get us thinking about the next steps in providing world-class perioperative care. You'll find the full lectures in our back catalogue, or join us at the upcoming Perioperative Practicum for expert discussions, business case tips, and hands-on workshops. Go to www.edpom.org and look for our international programme of perioperative practicums. Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. I'm here with Monty, Mythen, editor-in-chief of Top Med Talk, but we also now have graced with the presence of Dr. Angela Bader.
Thank you so much for inviting me.
Yeah.
I think this is a wonderful idea.
Oh, I love that you came and sat down. So, Angela, you're the director at the Weiner Center for Preoperative Evaluation.
Right now, I'm the vice chair for perioperative medicine. I transitioned in January.
Okay.
And David Hepner is the new medical director of the clinic.
Gotcha.
Yeah.
Interesting. And you're at Brigham.
Brigham, right,
Yeah,
exactly.
Brigham.
So one of the things that we did get the hospital to give us money for, which was amazing, is starting in conjunction with the pre-op clinic, a center for geriatric surgery and palliative care.
Awesome.
Which is something that I honestly don't know if there is something with a similar... Are you aware of any, Monty, of a center for that with that sort of focus?
I'm not. No.
Yeah. You would if there was.
I was going to say,
you would know it, yes. And it's being run. The other part that I think is really great is it's being headed by a surgeon who's a woman surgeon who's boarded both in surgery and palliative care. She's one of the few surgeons in the country that's boarded in both surgery and palliative care. And she and I run a research group, which will be the research arm of this center. But the goal is really to focus on identifying geriatric patients that can benefit from preoperative interventions. And this is the pre-op clinic is one piece. I think this is trying to take it to a new level. So this literally, we're just having the first meeting, so we're trying to put this together from an organizational perspective. And I think what also is very nice is it's a multidisciplinary effort that involves geriatrics, palliative care, anesthesia, and it's going to live in the Department of Surgery because it's really a surgical initiative, which I think is one way of hopefully ensuring hopeful success, because with surgeons actually being involved in starting it, I think that surgical buy-in is going to be less of an issue. I think they'll be much more welcoming.
Yeah, I got a little skin in the game on this one.
Exactly.
So it's specialist care of the elderly surgical patient has become relatively common, and we've interviewed numerous...
so the POPs.
But it's the palliative care twist that I haven't heard before.
Exactly.
Yeah.
Can you expand on that bit?
Sure. So as Monty knows, because he was kind enough to have me lecture several times on this topic, I am very, very interested in high-quality shared decision-making. Mm-hmm. And Zara Cooper, who's the surgeon who's starting the center with me, we really need to have the mindset changed so that sometimes not doing surgery is the right
answer.
And as Amir said earlier, we are in this crazy race where everything is based on volume. Yep. So we really need to get away from that and really focus on value, which is patient-centered outcomes, over cost, instead of just doing the volume and not really caring what happens 2 months, 3 months, 4 months. Mm-hmm. So our goal is to see if we can better standardize including high-quality shared decision-making as part of the overall geriatric optimization preoperatively. So I think that's a little bit different. And then secondly, I think, as Monty knows, we're very interested in elderly patients with cognitive dysfunction. And most clinics, at least in the U.S., don't even measure it. Do you measure that in the U.K., cognitive function preoperative?
Not universally. So it's recommended now. And we, the clock face idea, the say three things, the mini cog idea is often talked about. But not reliably universally delivered. I don't think it will be that long until it becomes standard.
Right. So
people are listening. People are listening.
Yeah, I think so too.
So I think, just to summarize very briefly for those who may not know, so we did some research. Surprisingly, it was the first time somebody actually looked at a preoperative population above age 65 and did standard mini-cog evaluations, and what we found, which was actually published in Anesthesiology, if anyone's interested, 2 publications.
Okay.
The first one showed that overall there's a 29% incidence of previously undiagnosed cognitive dysfunction. That's huge.
Yeah.
And if you were above age 75, it was 40%.
Wow.
And this is
crazy.
Eliminating people that had a diagnosis already. So I feel like we've turned over a rock, and now what are we going to do with the results? And then we did a follow-up study which showed that people with previously unidentified abnormal cognitive stratification have longer lengths of stay. More of them go to a facility instead of home, and they have more complications. So it matters.
It does.
It matters. And it's a huge burden. And so now that we've sort of shown this, we have to figure out what to do.
I say, so what is the next? I mean, what are you guys doing for the next
I
one?
think it's a center for geriatric surgery.
Yeah, of course.
Well, it's not just having a center. What it is a population management where you identify these groups at risk, and you have a preoperative plan of how you're going to deal with that specific patient's issues, whether it's cognitive issues, frailty, etc. Now, you may be familiar with, I'm sure Monty is, that the American College of Surgeons has come out with new guidelines for how geriatric patients should be taken care of, and I don't think most institutions actually will meet those guidelines because they involve cognitive testing and all of this attention to things that in most cases all we cared about was doing the
Looked
volume.
over.
Don't even, just get the patient in, do the volume.
Yeah.
And then especially when patients are in situations where you don't have a pre-op clinic,
how do you even how can you even manage?
they ignore it. So I hope that... And the reason they ignore it is because we get paid for doing the case.
Yeah.
And there hasn't been motivation to think about really optimizing preoperative care and having a goals of care discussion.
Well, I think so many times, too, we never really look at our patients from the anesthesia world.
I know.
We don't look at our patients post-operatively.
I think
there's not a lot of follow-up, especially if you're not in an academic setting.
Right, exactly.
You're not doing that. And so I think that's part of it, too. They're fine when I drop them off.
Right. Well, I don't know, Monty, what you think the U.S. versus the U.K., but I think one of the big problems is that anesthesia people in training don't learn that this is important.
Yeah.
Do you teach that in the UK training?
We hope big time.
Yeah, see, that we're really missing. So I've been doing...
And I think the med students are getting it now much better as well.
Well,
if you see what I mean.
Do you think it's still behind here?
Oh, God. Well, I went to medical school at Harvard. We didn't learn it then, and the medical students I teach say it's not
still not in there.
Right.
Oh, man.
So roughly speaking now, surgery in our institution is taught around a spine of perioperative medicine.
That's wonderful.
So that's the spine of the surgical training.
Yeah, that's what
and
we
those
miss.
issues are mainstream discussion points.
Right.
And certainly in anesthesia training, it's mandatory now to do the shared decision making.
Right, exactly.
Understanding the challenges of the elderly surgical patients and end of life decisions.
Right.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now all you need to do is find us on social media. We can be friends on Facebook. We can follow each other on Twitter. We can hang out on Instagram. Or we can even gorp at each other on YouTube. Get onto your social media platform, whichever your favourite is, and you're likely to find Top Med Talk there. Whilst you're at it, make sure you've subscribed to this podcast so you never ever miss an episode. Helps us enormously if you do that, by the way. And check out the website, topmedtalk.com. On there you can find the email updates where we update you as to what we're doing each week. And whilst you're online, whilst you're doing your thing on the internet, I highly recommend you download all of the podcasts that we've put out here on Top Med Talk. We do an enormous amount of material here. A lot of it is incredibly valuable and, of course, will be in the future. So I just recommend you download the entire back catalogue if you could. Helps us out if you do that as well. And check out edpom.org/meetings, because if you go on there, you can find out where we're recording and what we're doing, because we go to the big meetings, the EdPom meetings. You may have noticed most of our material comes from some of these wonderful conferences that are organised by evidence-based perioperative medicine. So edpom.org/meetings.